Good morning. My name is Adeline Gilbert, and today I'll be presenting my capstone project titled End-of-Life Care Training in the Surgical Trauma ICU. This project examines current gaps in end-of-life communication in the STICU and proposes structured training programs for nurses to improve communication, patient satisfaction, and nurse confidence. Thank you for being here. Here are the objectives for today's presentation. By the end of this presentation, you will be able to describe the problem of delayed and inconsistent end-of-life care communication in the STICU. You will be able to explain the rationale for implementing structured nurse-led EOL communication training. You'll be able to summarize key evidence supporting experiential and multimodal EOL education. You'll be able to identify proposed implementation steps for a 3-month pilot training program, and you'll be able to understand evaluation metrics for nurses, patients, and families, and clinical outcomes. In the STICU, end-of-life conversations are essential but often extremely challenging. These discussions help patients and families understand prognosis and clarify goals of care. Unfortunately, in trauma and surgical ICUs, deterioration can happen quickly, which makes timely communication even more important. When these conversations are delayed, it increases physical distress for patients, emotional distress for families, and moral distress for the nurses who witness prolonged suffering. Currently, end-of-life discussions in the STICU are frequently delayed and often solely led by physicians. Nurses rarely receive formal training in how to initiate or participate in these conversations. This results in inconsistent communication, dissatisfaction among families, missed opportunities for earlier, more compassionate decision-making. And nurses often feel unsure about their role, which leads to hesitancy and confusion. Many nurses report that they are encouraged to leave it to the doctors when it comes to end-of-life discussions, even though they're the ones who spend most of the time at bedside. Misunderstandings about legal and ethical boundaries further contribute to delays, but the literature makes it clear that nurses want to be involved, but they lack the training and tools to confidently engage in these conversations. This presentation proves that structured education can help bridge this gap and empower nurses. The primary purpose for this project is support implementing structured EOL communication training for STICU nurses. The goal is to improve the timeliness and quality of end-of-life discussions, enhance nurse confidence, and decrease stress and moral distress among staff. Ultimately, this training aims to ensure patient and family needs are met with compassion and clarity. Research shows that end-of-life discussions are often rushed or occur briefly on rounds without any privacy or adequate time for meaningful dialogue. Families often feel unprepared when late conversations result in confusion or distress. These discussions are commonly led by inexperienced physicians with minimal nurse participation, despite the fact that nurses have valuable insight to patient and family readiness. From an ethical standpoint, timely and compassionate communication supports patient autonomy and dignity. Nurses are at the bedside continuously, giving them a unique insight into patient wishes and family needs. When nurses are excluded from these discussions or do not feel prepared, it creates ethical gaps that can impede patient-centered care. Training nurses in this supports an ethically sound and collaborative approach. My project focuses on this central question. In adult trauma ICU patients, how does training ICU nurses in end-of-life care and communication compared to no formal nurse training lead to earlier and higher quality discussions, improved family satisfaction, and increased nurse confidence? This is the literature review part of this presentation. So first up is educational needs. The literature highlights the need for clear, broad guidelines for EOL communication that fit diverse ICU settings. Training programs must also accommodate nurses at different experience levels. Active listening skills, including eye contact, summarizing, and verbal acknowledgement, are consistently noted as essential components. Following professional ICU practice standards ensures training aligns with evidence-based care. Several resources support structured EOL training. This includes competency documents, palliative care curricula, and professional practice standards. Checklists are especially helpful because they improve consistency and prevent important topics from being missed. Research also emphasizes that continuous education, rather than a one-time class, leads to greater long-term improvement. The evidence shows that simulation-based learning significantly improves nurse competence communication skills, as well as shadowing hospice staff enhances nurses' comfort in EOL communication. And in contrast, everybody's favorite, computer-based training, e-modules, tend to have minimal impact. These findings support a multimodal, experience-based approach. This slide shows the 7 steps of the Talking About Death model. It's also called TAD. TAD model is a structured framework to guide EOL conversations. This starts as opening the discussion, exploring a patient's understanding of their prognosis or just what's happening, assessing their wishes, defining goals of care, co-creating a care plan, summarizing, very important, and addressing any remaining questions from patients and family. This structured process helps guide emotionally complex conversations that can sometimes just go off the rails, just in a completely opposite direction. So this is a good model to go by. Talking About Death workshops have been shown to improve provider knowledge and communication skills. They include visual tools, e-learning modules, role-playing scenarios, and reflective exercises. This multimodal format allows nurses to practice and build confidence in a supportive environment. Another tool is the Curative to Comfort Care Transition Toolbox. This helps nurses recognize when patients are declining, when their health is declining, and they may, in realizing that this patient may benefit from transitioning to comfort-focused care. The literature shows that when nurses use this toolbox, patients experience what is described as a good death, which is in the literature defined by comfort, dignity, and compassionate communication. Evidence-based nurse training studies. There was one study which used multimodal training, including lecture, simulation, and bedside education, which reported significant improvements in nurses' knowledge, awareness, and performance. Units that provided pamphlets and educational materials at the nurses' station saw ongoing improvement in practice. Another study, which evaluated a 2-day end-of-life course, found that nurses gained confidence in symptom management, medication advocacy, and initiating advanced care planning conversations. Many nurses reported that the training opened conversations that may have been avoided otherwise, and they demonstrated meaningful improvement in communication readiness. Now that the literature review part is done, we are going to move on to implementation, evaluation, and dissemination. Stakeholders. The primary stakeholders are the STICU nurses. They will be the ones initiating and supporting end-of-life discussions. Secondary stakeholders include surgeons and residents who can collaborate on the decision-making. And the ultimate beneficiaries are patients and their families, who will receive clear, more compassionate communication. Successful implementation will require collaboration with hospital administration, nursing professional development, or NPD, informatics and IT teams, and the palliative care team. Approval from leadership, such as the CNO, the Director of Critical Care, and the Medical Executive Board, is necessary before initiating this pilot. The 3-month pilot includes a structured workshop taught by EOL communication champions, a shadow shift with the palliative nurse practitioner team, rounding with the palliative care service, and training tools using the talking about death model and the curative to comfort care transition toolbox. Printed materials will also be placed at the nurses station for continuous learning. A key part of this program is integrating a standardized documentation checklist into the electronic medical record. This will help us with audits and timing, kind of like tracking timing and stuff. This checklist will incorporate components of the Talking About Death model and the Comfort Care Transitional Toolbox, which allows tracking for conversations and care. All full-time STICU nurses will complete the training program. Patients who transition to hospice or have an allow natural death order will be included when analyzing outcomes. After the pilot is evaluated and refined, the training will be added to annual competencies, the critical care nurse residency and fellowship program, and STICU standard procedures. Eventually, it will become a part of hospital-wide policy. Evaluation will measure changes in nurses' competence, preparedness, communication comfort, and frequency of initiating end-of-life conversations. The end-of-life professional caregiver study will be used to assess these outcomes. Family satisfaction will be evaluated by using the Family Satisfaction in the ICU survey. This includes measures such as clarity of communication, compassion, emotional support, and time available for questions. Clinical metrics include time from ICU admission to the first documented end-of-life conversation, number of nurse-initiated conversations, completion of EMR documentation checklists, family satisfaction scores, and these will demonstrate whether training leads to measurable clinical improvements. Success will be measured by a 20% increase in EPCS scores, a 24-hour reduction in time to first end-of-life conversation, a 20% increase in nurse-led discussions, and a 15% increase in family satisfaction scores. Data will be collected at baseline and then again at 3 months, 6 months, and 1 year. Sources include the EMR, nurse surveys, and family surveys. This allows us to track both short and long-term outcomes. Results will be shared with STICU leadership, trauma surgery, palliative care committee, and hospital executives. Nursing professional development educators across all ICUs will also receive the findings, and they will be posted on the hospital's SharePoint website. Externally, the project will be presented at statewide and national conferences such as the Texas Nurse Association, the American Association of Critical Nurses National Teaching Institute, and the Hospice and Palliative Nurses Association. A manuscript will be submitted to Critical Care Nurse and Journal of Trauma Nursing, and the project will also be submitted to the Texas Board of Nursing for CEU approval. In summary, STICU nurses currently lack formal training in end-of-life communication, but evidence clearly shows that structured education leads to earlier, higher quality conversations, improved family satisfaction, and increased nurse confidence. Implementing a structured EOL communication training program has the potential to significantly elevate the quality of end-of-life care provided in the STICU. Thank you for your time.